I live 129,000 minutes in 3 months with my disease, and you want to change something of my behavior. If you see me 10 minutes, maybe 20 minutes in 3 months, how can we manage these kind of things? I use the Prochaska stages of behavioral change. And the first stage is the pre-contemplation. Your patients say, I don't care, I don't want your treatment. And we need to explore the representation, the fears of the patient, and what is going behind of that. And the second part is the contemplation. I think it's the most well known, it's the more common. And as we said before, I know, but I don't do the physical exercise. And we need some tools. For that, we should have open questions. And this makes the patient more comfortable, and he will express himself and probably the emotion. You create a very nice relationship with the patient if you understand better the patient. Accept the patient unconditionally, and to have empathy and readiness to let him grow. And the second tool is to listen actively and to reformulate, to make sure that you understand the patient. And the patient feels understood, you decrease the resistance of the patient. If your husband says yes, but he resists, he's not agreeing with you. So depict all the time the but. The but is the most important point word to detect. We need to develop the discrepancy of the patient. I know, but I'm not doing. And this, we should work very deeply with the patient. That's the best way to explore his ambivalence. We are talk too much during the consultation. And we don't know how to listen. We don't know how to observe. We should listen to the patient with our third ear. Which kind of messages he wants to tell us? What is his main worry, his deep need? We have to look at the behavior of the patient, how he sits in his chair, his emotion, his breathing, his body language. This is very important. We are not trained to do these kind of things. The third one is to support, search for success, and valorize what is already succeeded. We are really bad for that. We should say positive things, even if it's a small progress, even if it's much less than before. It's very, very important to support the self-efficacy of the patient. And finally, use the mistakes. And finally, we should summarize time to time, in the middle of a consultation, the patient's own motivation to change, reformulate what he is willing to do, and I will remind the patient of his ambivalence. You know, you tell me things like this, but on the other side, your value is this. You are external of the internal thinking of the patient. And finally, don't give your opinion all the time, but sometimes a while is worthwhile. And the third one, also very common, maybe the patient is agreeing to start, but in fact, you need to negotiate objectives, and small objective, baby step by baby step. 85% of the patients in your consultation are in these 3 stages. And we are quite arrogant to ask the patient to do physical activity, to do a diet. They are not ready. You have to search for obstacles. We have to look at with our patient who is always supportive, who is mostly supportive, and who are not supportive, in order to find the sabotagers, husband, neighbors, colleagues at work. They are jealous of you if you do some diet, if you lose weight and they are not successful. A second key is the forbidden food. It's no forbidden food. You have food you can eat every day, occasionally or rarely, but forbidden food is the most dangerous. To maintain really a change in the behavior field, you need to reinforce the benefits all the time. Congratulate your patient, fantastic, you are successful, even if it's a lower objectives. And one part of this model is the relapse. It's part of the game. We hate to talk about relapse to the patient. We should do. And if you do not prevent this kind of relapse, you lose the patient. And I prefer small mistakes instead of relapse. You should not have more than 3 red flags. You cannot do 3 times in a row a mistake. You cannot do 3 days in a row your birthday. If you do some physical exercise, if you miss 3 times the appointment or to go to the gym, you don't go for the 4th time. So 2, maximum 3, it's really borderline. After that, you stop everything. Evoking change talk. The first part is the pre and the contemplation stages. So it's at the early beginning of the willing to change, preparatory change talk. And the patient will say, you know, I'd like to change, I'd like to lose weight. Maybe I could change my lifestyle, maybe to smoke less. Sometimes patients give you reasons. I need to change because my blood pressure is too high. And the second part is the preparation. And at the end of the hill is the action. And the mobilizing change talk is a bit more. Patient is in commitment. He says something that, well, I take the decision to do some physical exercise. I promise I will start the diet. Every time a patient says something in the discussion like this, they evoke a change talk. And this is not easy. You have to hear with your third ear. Every time they say something, you pick up and you start again and you work on that. Ask the person to elaborate or to make a comment, positive comment. You have to reformulate what the patient is saying and to summarize. Change is difficult and cannot be prescribed. Frankly, we have to find a way to understand the patient, what he's willing, wishing, able to do it. And I say the most important is to develop this stage of ambivalence, the contemplation stage. It's important to roll with resistance, not to push the patient. Recognize, elicit, and reinforce change talk is a very useful technique. Patient education is like a tango. Try to dance instead of fighting.